Tuberculosis. Tuberculosis, TB, caused by Mycobacterium tuberculosis, still has a worldwide distribution with a very high prevalence in Asian countries where 60 to 80% of children below the age of 14 years are affected. The WHO estimates that 1/3 of the world's population is infected by the tubercle bacillus, with 10 million new cases in 2019. It remains a deadly disease, with about 1.5 million people worldwide dying of TB every year and 10 million new cases a year. Clinical features. TB can be a mimic of other diseases and a high level of suspicion is necessary to consider the diagnosis, especially if there are only extrapulmonary manifestations. There may be no symptoms or signs, even in advanced disease, and may be detected by mass screening. Ideally, patients should be referred early for specialist management. Respiratory symptoms: cough, sputum, initially mucoid, later pleural and hemoptysis dyspnea. General clinical features, usually insidious anorexia, fatigue, weight loss, fever, low grade, night sweats. Physical examination may be no respiratory signs or may be signs of fibrosis, consolidation or cavitation, amphoric breathing, finger clubbing. High-risk people/situations: newborn and infants, adults over 60 years, patients with HIV/AIDS, chronic disease, for example diabetes, crowded or unsanitary living conditions, people affected by alcohol and drugs, immigrants and refugees from endemic countries. DXD, malaise plus cough plus weight loss plus or minus fever/night sweats plus hemoptysis. Pulmonary TB. Primary infection. The primary infection usually involves the lungs. Transmission is by droplet infection. The focus is usually subpleural in the upper to mid zones and is almost always accompanied by lymph node involvement. Erythema nodosum may accompany the primary infection. Primary TB is symptomless in most cases, although there may be a vague, not feeling well illness associated with a cough. In most people, this pulmonary focus heals but leaves some surviving tubercle bacilli, even if it becomes calcified, the gone focus. Progressive primary tuberculosis. If the immune response is inadequate, progressive primary TB develops, with constitutional and pulmonary symptoms. Rarely, hematogenous spread can occur to the lungs, miliary tuberculosis, to the pleural space, tuberculosis pleural effusion, or to extrapulmonary sites such as the meninges and bone. Latent TB infection is the presence of infection without evidence of active disease, contained by the immune system, and inability to transmit the infection. Latent TB is very common in children in and from developing countries. The standard preferred regimen is isoniazid, 10 mg/kg up to 300 mg oral daily for 6 to 9 months. Symptoms of active TB include persistent cough, sputum production, hemoptysis, fever, sweating, malaise, weight loss and anorexia. The factors causing this include poor social living conditions with malnutrition, diabetes and other factors lowering natural immunity, such as immunosuppressant drugs, corticosteroids, lymphoma and HIV infection, later stage. The chest X-ray is usually abnormal, classic apical disease with infiltration and cavitation with fibrotic changes. Reactivated pulmonary TB. This usually presents with constitutional symptoms of poor health and night sweats, and a cough that is initially dry but may become productive and be bloodstained. Extrapulmonary involvement seen in the figure. Miliary tuberculosis. This disorder follows diffuse dissemination of tubercle bacilli via the bloodstream, especially in those with chronic disease and immunosuppression. The symptoms, which are insidious, include weight loss, fever and malaise. The classic chest X-ray is multiple 1 to 2 mm nodules in lung fields. It is fatal without treatment. It is fatal without treatment. TB in children. Children living in close contact with people with smear-positive pulmonary TB are highly vulnerable to acquiring the primary infection. A possible complication is miliary TB. Primary disease is the more common form in young children. Reactivation is more common in adolescents. Diagnosis. Tests include MAN2 tuberculin test, chest X-ray, CT scan if doubtful, sputum or bronchial excretion or gastric aspirates for stain, acid-fast bacilli, and culture. Ideally requires 3 specimens over 3 days, including 1 early morning immunochromatographic finger prick test, new and promising, interferon gamma release assay, IGRA. Quantiferin TB gold blood test, not/PCR test, less sensitive than culture. Biopsies on lesions/lymph nodes may be necessary. The hallmark is caseating granulomata. Fiber optic bronchoscopy to obtain sputum may be necessary. Consider HIV studies. Tuberculin, MAN2, testing and BCG vaccination. A tuberculin, MAN2, test should be performed prior to BCG vaccination in all individuals over 6 months of age. It is read at 48 to 72 hours. It is not a good test to diagnose TB. If area of induration, 5 mm, significant and immunocompromised, close contacts and HIV infection greater than 10 mm, positive equals tuberculosis infection, active or inactive, greater than 15 mm, highly significant for normal people. The BCG vaccination should be given if the reaction is 5 mm. BCG vaccination is recommended for Aboriginal and Torres Strait Islander neonates in regions of high incidence, neonates born to patients with leprosy or family history of leprosy, children less than 5 years traveling for long periods to countries of high TB prevalence. BCG vaccination should be considered for neonates in household with immigrants or visitors recently arrived from countries of high prevalence. Note: tuberculin test not necessary for neonates 5 years with significant exposure. BCG vaccination is contraindicated for tuberculin reactions greater than 5 mm, immunocompromised or malignancies involving bone marrow lymphatics, can disseminate infection, high-risk HIV infection, significant fever or intercurrent illness, including generalized skin disease, scolioid tendency, pregnancy, previous infection. Management and treatment. Referral to experienced specialist care is appropriate. The current antimicrobial treatment is the standard short-course therapy with 4 anti-tuberculous drugs initially, rifampicin plus isoniazid plus pyrazinamide plus ethambutol, daily for 2 months, then rifampicin plus isoniazid daily for a further 4 months. The usual precautions with adverse reactions are required. Pyridoxine 25 mg daily is recommended for adults taking isoniazid. A 3 times weekly regimen is also an option if DOT is employed. Corticosteroids may be prescribed. Notify appropriate jurisdictional public health authorities. Promote healthy lifestyle advice. Toxicity of therapy. All of the TB medications cause hepatotoxicity, but do not stop them unless the transaminases rise to 3 to 5 times the upper limit of normal.